What does a typical primary care visit look like for a patient with chronic liver disease? And what clinical findings or changes during a primary care visit might prompt a referral to oncology?
In a lot of cases, patients with chronic liver disease, right up until they develop decompensated liver cirrhosis, may have no symptoms whatsoever. So patients may or may not present with the knowledge that they have chronic liver disease. And really, the decision about whether someone does may be based as much on their risk factors for liver disease, such as alcohol use, metabolic risk factors for metabolic dysfunction associated steatotic liver disease, or risk factors for chronic viral hepatitis, for example, might mean that you're having a consultation with someone who has chronic liver disease that's based on those risk factors alone rather than any specific symptoms of liver disease. In terms of what might make us more suspicious that a patient has liver cirrhosis, um, or may have the likelihood of hepatocellular carcinoma, this may be that the patient is jaundiced or has abdominal pain or itch, or has some blood work done. This may be accompanied by some tests that have been done, such as imaging tests like ultrasound or a fibroscan, which would give us some indication that the patient has either fibrosis measured on a fibroscan or cirrhosis, or signs of portal hypertension or cirrhosis on an ultrasound scan.
What are the main challenges that primary care providers face in identifying liver cancer at an early stage? And how can they be better supported so they can recognize high-risk patients sooner?
Often liver disease is asymptomatic, even at the stage of early cirrhosis or in a patient who may have liver cancer. Having some way of knowing which are the risk factors which are most likely to be associated with chronic liver disease, and particularly which risk factors are most likely to be associated with cirrhotic liver disease or liver disease that may put patients at high risk of hepatocellular carcinoma, such as hepatitis B infection, would be very useful to be able to support us to recognize these patients earlier. So some kind of protocols or pathways in place which suggest to us that when we see a patient with certain risk factors, it would be normal to check and test for cirrhosis and or hepatocellular carcinoma. The other thing that would make us feel supported to be able to find patients with cirrhosis or hepatocellular carcinoma or both would be to have the tests available for us to be able to request directly from primary care rather than having to make referrals into secondary care.
How can policymakers address these challenges to improve liver cancer screening and diagnostic pathways in primary care, particularly for high-risk populations?
I think the most important thing is to come up with nationwide or regional or international strategies to be able to routinize and embed liver disease detection and management into primary care settings. It's normalized for primary care to try and detect and find early liver disease of all etiologies, and therefore by finding liver disease earlier, knowing who the patients are who have cirrhosis, to be able to put them into surveillance programs, refer them to secondary care, or to be able to carry out interval testing to make sure that they haven't got progression of liver disease to cirrhosis. This can only really be achieved at a higher policy level rather than an individual practitioner level to stop this variation in practice in the management of liver disease. And I think we can see examples from other conditions. So it's crucial that we have this high-level policy-led national agenda to be able to standardize and incentivize pathways of care to both detect chronic liver disease in general and also to detect and manage hepatocellular carcinoma.
How can medical education be enhanced to ensure primary care physicians are better equipped to detect early signs of liver cancer and understand when to refer patients for specialized testing?
A very good start would be to expand the curriculum section on liver disease within this, which tends to be encompassed within the section on gastroenterology and generally given less importance or less space than the training on luminal gastroenterology. Initiatives like the pilot in NHS England Southwest of trying to develop a curriculum for GPs with an extended role in gastroenterology and hepatology is useful. Another useful for postgraduate training for GPs to subspecialize or develop a special interest in something like liver disease, which would help with the education of primary care more generally as that intermediary between primary care and secondary care. So I think changes can be made both to undergraduate and postgraduate training to give liver disease the same airtime as other conditions, to be able to put to trainees the importance of liver disease in their portfolio of training around long-term condition management and around early detection of cancer management.